Which of the following describes the primary hemodynamic effect of intra-aortic balloon counterpulsation during inflation? A. Decreased coronary artery perfusion pressure. B. Increased myocardial oxygen demand. C. Increased coronary and cerebral perfusion pressure. D. Decreased systemic afterload. Answer: C. Increased coronary and cerebral perfusion pressure. Explanation: the intra-aortic balloon inflates during early diastole, triggered by the dicrotic notch. This sudden volume displacement pushes blood backward toward the aortic root, significantly increasing aortic diastolic pressure. This process, called diastolic augmentation, directly increases coronary artery and cerebral perfusion pressures. An IABP should be timed to deflate precisely at which point in the cardiac cycle? A. At the onset of isovolumetric contraction, just before systole. B. At the dicrotic notch. C. In the middle of diastole. D. Simultaneously with the closing of the mitral valve. Answer: A. At the onset of isovolumetric contraction, just before systole. Explanation: deflation must occur right before the aortic valve opens, at the end of diastole/onset of isovolumetric contraction. This rapid deflation creates a vacuum effect, sinkhole effect, in the aorta, which drops the pressure the left ventricle has to pump against. This reduces systemic afterload and decreases myocardial oxygen workload. In which of the following patients is the use of an IABP absolutely contraindicated? A. Severe cardiogenic shock secondary to acute MI. B. Acute mitral regurgitation with papillary muscle rupture. C. Severe aortic regurgitation. D. Intractable ventricular arrhythmias. Answer: C. Severe aortic regurgitation. Explanation: severe aortic regurgitation is an absolute contraindication. Because the balloon inflates during diastole to force blood backward toward the coronary arteries, an incompetent aortic valve would allow that augmented blood volume to surge directly back into the left ventricle. This causes severe, acute left ventricular distension and failure. Severe aortic dissection is the other primary absolute contraindication. While monitoring an IABP waveform, you notice that the balloon is inflating before the dicrotic notch is reached on the arterial pressure trace. This error is known as A. Late inflation. B. Early inflation. C. Early deflation. D. Late deflation. Answer: B. Early inflation. Explanation: early inflation occurs when the balloon inflates before the aortic valve closes, prior to the dicrotic notch. This is highly dangerous because the balloon inflates while the left ventricle is still trying to empty, causing premature aortic valve closure, an abrupt increase in afterload, and increased myocardial oxygen demand. Which timing error is most hazardous because it forces the left ventricle to contract against a still inflated balloon, dramatically increasing afterload? A. Early inflation. B. Late inflation. C. Early deflation. D. Late deflation. Answer: D. Late deflation. Explanation: late deflation means the balloon remains fully or partially inflated during the onset of the next ventricular systole. The left ventricle is forced to pump against the physical obstruction of the balloon, which drastically raises afterload, increases myocardial oxygen consumption, and reduces cardiac output. What is the correct anatomical positioning for the tip of an intra-aortic balloon pump catheter? A. 1 to 2 cm distal to the left subclavian artery takeoff. B. Just proximal to the celiac trunk. C. Inside the left ventricular outflow tract, LVOT. D. In the ascending aorta, 2 cm above the aortic valve. Answer: A. 1 to 2 cm distal to the left subclavian artery takeoff. Explanation: the tip of the balloon should sit in the descending thoracic aorta, approximately 1 to 2 cm distal to the origin of the left subclavian artery. If it is placed too high, it can occlude the left subclavian or carotid arteries. If placed too low, it can compromise perfusion to the renal and mesenteric arteries. If an IABP catheter is placed too low in the descending aorta, which clinical sign or laboratory finding are you most likely to observe first? A. Loss of the left radial pulse. B. Sudden drop in urine output. C. Acute hepatic failure. D. Elevated cerebral perfusion pressure. Answer: B. Sudden drop in urine output. Explanation: a low-lying balloon can obstruct the renal arteries during inflation. This diminishes renal perfusion pressure, leading to an abrupt decline in urine output. Positioning must be verified via chest X-ray. The tip should be at the level of the second or third intercostal space or just above the carina. Why is helium standardly used to inflate the intra-aortic balloon rather than atmospheric air or oxygen? A. It provides better anticoagulation properties. B. It has low density, allowing rapid inflation and deflation cycles. C. It increases the oxygenation of the adjacent aortic blood. D. It prevents the balloon material from degrading. Answer: B. It has low density, allowing rapid inflation and deflation cycles. Explanation: helium is an extremely low-density gas, which allows it to travel rapidly through the catheter lumen. This low resistance ensures nearly instantaneous inflation and deflation, matching rapid heart rates. Additionally, helium is highly soluble in blood, reducing the risk of a catastrophic gas embolism if the balloon ruptures. During a shift, you notice a sudden appearance of blood flecks or brown flakes inside the translucent IABP tubing. What does this signify? A. Normal condensation from temperature changes. B. High shear stress causing hemolysis outside the balloon. C. Balloon rupture or perforation. D. Normal backflow from high diastolic pressure. Answer: C. Balloon rupture or perforation. Explanation: the presence of blood or coffee ground-like material, dried blood, in the pump tubing indicates a balloon leak or perforation. The helium gas mixes with blood inside the balloon. If this occurs, the pump must be paused immediately, the patient placed in a flat or Trendelenburg position, and the catheter prepared for urgent removal to prevent gas embolism or entrapped clot formation. A patient supported by an IABP develops new-onset atrial fibrillation with a highly irregular, rapid ventricular response. Which trigger mode is most appropriate for the console? A. ECG/pattern mode. B. Pressure/arterial trigger mode. C. A pace/ventricular pacing mode. D. Internal/asynchronous mode. Answer: A. ECG/pattern mode. Explanation: most modern IABP consoles use advanced ECG pattern tracking algorithms as the default. In highly irregular rhythms like atrial fibrillation, the console tracks the R wave dynamically to deflate the balloon ahead of systole. Pressure triggering can be used as a backup if the ECG signal is lost, but it struggles with rapid, irregular rates due to varying pulse pressures. For which of the following clinical scenarios is an IABP most strongly indicated? A. Cardiogenic shock due to an isolated right ventricular infarction. B. Decompensated heart failure due to severe chronic aortic stenosis. C. Mitral regurgitation secondary to acute papillary muscle rupture post-MI. D. Prophylaxis during routine, uncomplicated diagnostic coronary angiography. Answer: C. Mitral regurgitation secondary to acute papillary muscle rupture post-MI. Explanation: acute mitral regurgitation, MR, secondary to papillary muscle rupture is a classic indication for an IABP. By dramatically lowering aortic afterload during systole, the balloon reduces the systemic resistance that drives blood backward through the incompetent mitral valve into the left atrium. This shifts blood flow forward into the systemic circulation, stabilizing the patient as a bridge to emergency surgery. The IABP console suddenly alarms for low augmentation. Which of the following is a potential cause of this alarm? A. Severely low systemic vascular resistance, SVR, or hypotension. B. Severe systemic hypertension. C. Tachycardia with a heart rate of 65 bpm. D. Excessive balloon volume. Answer: A. Severely low systemic vascular resistance, SVR, or hypotension. Explanation: diastolic augmentation relies on adequate intravascular volume and vascular tone. If a patient is severely hypovolemic or has profound vasodilation, low SVR, there is less blood volume/resistance in the aorta for the balloon to push against, resulting in a low augmentation pressure trace. Other causes include balloon underinflation or improper positioning. Which of the following is the most common vascular complication associated with the use of an intra-aortic balloon pump? A. Aortic dissection. B. Mesenteric ischemia. C. Limb ischemia. D. Renal artery thrombosis. Answer: C. Limb ischemia. Explanation: limb ischemia, occurring in up to 5 to 15% of patients, is the most common complication of IABP therapy. It is caused by the large bore sheath obstructing arterial flow down the femoral/iliac artery, local thrombus formation, or distal embolization. Routine assessment of distal pulses, skin color, and temperature in the lower extremities is mandatory. A patient with an IABP is stable on a 1-to-1 assist ratio. Due to clinical improvement, the team decides to wean the support. Why is a 1-to-4 assist ratio typically the lowest frequency utilized before complete removal? A. The console software automatically shuts down below 1:4. B. Lower assist ratios increase the risk of thrombus formation on the stationary balloon surface. C. The patient's coronary perfusion drops to 0 if left unassisted for more than 3 beats. D. It prevents the balloon from losing its structural helium charge. Answer: B. Lower assist ratios increase the risk of thrombus formation on the stationary balloon surface. Explanation: when the balloon remains deflated for multiple consecutive cardiac cycles, such as in a 1-to-4 or 1-to-8 ratio, blood can stagnate against the outer folds of the balloon material. This dramatically increases the risk of clot formation on the balloon surface, which can cause a thromboembolic stroke or limb ischemia upon removal. If a patient tolerates a 1-to-4 ratio well, the pump should be pulled rather than kept at a lower setting indefinitely. Under what specific condition should the IABP console be switched to internal or asynchronous mode? A. When the patient is experiencing ventricular tachycardia. B. During electrosurgical cautery interference in the operating room. C. During cardiopulmonary bypass or cardiac arrest with no intrinsic cardiac activity. D. When the patient's systolic blood pressure drops below 70 mm of mercury. Answer: C. During cardiopulmonary bypass or cardiac arrest with no intrinsic cardiac activity. Explanation: internal, asynchronous, mode commands the balloon to inflate and deflate at a fixed, predetermined rate, typically 80 bpm, regardless of the patient's own cardiac activity. This mode is strictly reserved for scenarios where there is no mechanical or electrical cardiac activity to track, such as during cardiopulmonary bypass or continuous chest compressions during cardiac arrest, to help maintain minimal systemic and coronary perfusion.